Miller-Meeks is recognized for 5 minutes.
Thank you, Mr. Chair. My bill, the Treat and Reduce Obesity Act, is designed to effectively treat and reduce obesity in older Americans by enhancing Medicare beneficiaries' access to providers who are trained to administer intensive behavioral therapy under Part B, and by allowing Medicare Part D to cover FDA-approved anti-obesity medications. Dr. Hughes, CMS is viewed as a leader in treatment coverage policy and programs for chronic disease management. It is undeniable that obesity is a serious chronic disease that affects 42% of Americans and approximately the same level in older Americans enrolled in Medicare. We know that on account of its antiquated structure and rigid coverage limitations, traditional Medicare does not provide for flexible or customizable obesity treatment coverage policies in both Part B and Part D. The Medicare Modernization Act excluded coverage of anti-obesity medications in Part D, which made sense at the time given the paucity of available treatment options. As a result of the remarkable scientific research and innovation since the MMA, obesity has become recognized as a serious chronic disease with highly effective medications to treat it. Moreover, the rapid growth in obesity and related health and economic consequences was corroborated by the University of Southern California's Schaefer Center dynamic analysis, which suggested Medicare could save as much as $175 billion over 10 years if patients had access to new obesity treatments. Can you please detail any plans CMS has to update these coverage policies for obesity treatments and how your agency thinks about the trade-offs between increased utilization and obesity coverage on the front end with the prospective program and broader health system savings that may accrue over time?
Thank you. Thank you for that important question. And CMS certainly shares your view that obesity remains a serious and significant public health problem, particularly for our Medicare beneficiaries, particularly for underserved beneficiaries. As you note, we are prohibited by statute from covering drugs for weight loss under Part D. We would be willing to work with you on your proposal as it moves forward.
Thank you very much for your comments, and I will enjoy working with you on this issue. Mm-hmm. I'm also proud to see the Share the Savings with Seniors Act included in this hearing. This bill is full rebate pass-through for medicines used to treat chronic conditions such as diabetes, asthma, chronic obstructive pulmonary disease, congestive heart failure, and medicines used to prevent stroke. This ensures that patients who are most likely to face high out-of-pocket costs directly benefit from the savings that plans and PBMs negotiate on their behalf. A recent GAO report authored by today's witness, Mr. Dickin, found that beneficiaries pay more than their plan sponsor for nearly 80% of most rebated drugs. The report states that Part D plans received $48.6 billion in rebates from drug manufacturers in 2021, but went on to say that rebates do not lower individual beneficiary payments for drugs, as these are based on the gross cost of the drug before accounting for rebates. Dr. Hughes, while I understand that HHS did not concur with the GAO's specific recommendation in the report, I hope you'll agree with members of this committee that the status quo benefits industry actors at the expense of patients, especially low-income patients with chronic conditions. As with your agency's recent actions to address some of these rebate policy excesses through your recent DIR policy, will you commit to working with me and others on addressing this PBM malfeasance in Part D to lower patients' out-of-pocket costs?
Thank you, and thank you for the question. We certainly value transparency, want to make sure that our beneficiaries can afford medications. We would work with you on this proposal.